everyone. Good morning. Today we're joined by Dr. Stenehjem to give a COVID-19 update for the state of Utah to check in and see how we've been doing in the last little bit. Dr. Stenehjem, thanks so much for joining us. It's nice to see you.
Hello there. Good to be back.
So as always, let's start with case trends and kind of go over what's been happening since the last time we spoke. So our total case counts in the state of Utah are at 394,334, with yesterday's daily case count at 472, which was a 7.1% positive rate. We've had a total of 2,178 deaths, with one reported yesterday. Our hospitalizations are currently at 137. And for vaccines, we've given out a total of 1.9 million, with 1.2 million of those being first dose only, and 840,832 of those being fully vaccinated. Let's start with that. It seems like our case counts and hospitalizations and even that positive rate are going up just a little bit every day. Is there any connection between what's happening maybe in other places for that to be going up, or any reason for that to be going up right now?
You know, I'd say they may be up just a touch, but I think it's too early to say that this is much of a trend at all. I mean, I think when you look at the data and you look at kind of the past year, we're in a plateau phase. We are definitely, cases are in the lower range. They're kind of fluctuating a little bit, but we're definitely in a plateau. And if you look at essentially all the metrics that we look at in terms of kind of getting a sense of where we're at, they're all pretty consistent with that plateau phase, meaning that the cases are down and stable. The test positivity is about what it's been. Maybe it's down a little bit, which is encouraging because that kind of reflects then cases that come down shortly thereafter. Hospitalizations are down and stable. So I think I don't want to read too much into a slight increase here or a slight decrease there. Things are stable. We're in a spot where we don't have loads of people in our hospitals. That pressure has been taken off. And now we're in this phase where, the cases are still here, 400, 500, 600 a day, but they're at a stable rate.
And you mentioned that it seems like hospitalizations are staying that way too. How are caregivers doing? What is the atmosphere and vibe like when you go to do your rounding with those patients?
Yeah, I mean, it's so much better than it was, back in December and January. It was a pretty dark winter for a lot of us in healthcare. And, just moving into spring, our healthcare workers that want it are fully vaccinated. We feel protected. We have plenty of personal protective equipment. We're getting better at caring for our patients. We know how to treat this disease better. We have better drugs. So, the mood in the hospital, and I would say across, Intermountain in general, is one of improvement. We're kind of coming out of a really hard stretch for us, and things are getting better. And we'd love to see it kind of maintain that and stay that way.
That's great to hear. It's crazy that it's been over a year since this all started. And now we have a vaccine. We have multiple vaccines. And I want to touch a lot on the Johnson & Johnson vaccine today. Previously, it was the one-shot vaccine that was being given out, and it went on a pause about a week ago. And the CDC is actually currently meeting right now to decide whether to remove that recommended pause or not. And the White House actually said that they have plenty of doses ready to go as soon as the CDC says, okay, it's safe to give it again. Do we know any more research about these blood clots or what was causing them? Has anything been released to the public to look at?
I mean, there's some data in the scientific literature about kind of the etiology, why these blood clots have happened. First, I'd like to say this is a very, very rare event. And so 6 cases and about 6 million doses. So that's about 1 in a million, suffered this type of event. And so that's a very rare event. And we're seeing something similar with the AstraZeneca vaccine. And the reason that's important is that they're both the same platform, meaning that it use this incompetent viral vector to really deliver the DNA of this spike protein into our cells. And when you see it in 2 different vaccines using the same platform, it really increases your kind of plausibility of why this happens. And so what we think is happening is that these antibodies in a very, very small fraction of people are generating an immune response that can attack our platelets, which are clotting factors in our blood, which then has led to some clots. And those clots, in some cases, have been quite severe, especially when they're involving the brain. So they're about 1 in a million. CDC has come out with some data, and being struck by lightning is about 1 in 500,000. So just to put that in perspective, kind of how rare this event is. I also see this being a really important sign that our safety monitoring systems work. And so people were, rightfully concerned, especially because we haven't seen vaccines coming to market this fast, about safety. And we had these big, large trials that showed that they were safe. They included 40,000, 60,000 people. But when you're talking about an adverse event that's 1 in a million, you're never going to see that in a trial of 60,000 people. Trial of 60,000 people are going to show things that occur much more commonly. And so we have these kind of monitoring systems in place in the US and across the world that looks at this kind of post-marketing surveillance of like, what are really rare events that occur with vaccines or medications for that matter. And this is an example of this system working, and the fact that they saw 6 cases of this across the US, and they said, whoa, we got to pause and take a look at this data. That to me is just reassuring that our safety system is working. You're right there. The advisory council is meeting today. That's an independent group of experts that are, our nation's top experts in vaccinology. They're meeting to review the data and any other new data that has come in this past week. And then we'll make a recommendation to CDC and FDA about what to do on the pause. And so, it's hard to speculate what they're going to say. Hopefully we'll have some answers by this afternoon. And I hope that we can, go ahead and turn on the J&J vaccine distribution in a safe manner starting tomorrow.
Do you feel like the Johnson & Johnson vaccine is needed in order for the US to get herd immunity? That it seems like a shot that people want because it's the one shot. It's a lot easier for those who maybe can't take off as much work or for various reasons. Is it a necessary vaccine to get to that 70, 80%?
So it is a great vaccine. So, when you look at efficacy, it really is a strong vaccine, and it definitely would be a huge add to our suite of vaccines. Right now we have Pfizer, Moderna, maybe others coming along, AstraZeneca, Novavax, et cetera. But right now we have 2, and J&J would be the 3rd. It really is a nice vaccine to add to the suite of vaccines in the setting that you can go out and reach people in hard to reach places. One of the challenges of the Pfizer Moderna vaccine is you have to schedule that second dose, and you really should get that second dose really within that window of 3 weeks for Pfizer, 4 weeks for Moderna. And that just logistically is hard, but with a 1-dose vaccine, you could go into a workplace and you can go and you can offer the vaccine to people in the workplace. You can go and set up a mobile clinic in places that have been, have poor access, and just get everybody vaccinated. And you don't have to worry about that logistics of scheduling that second dose. And so it really is an important vaccine. Now, do we need it just strictly speaking based on sheer numbers? No, we're going to have enough Pfizer Moderna vaccine to anybody that wants one. However, J&J can really get out there and reach the population that may not have gotten the Pfizer and the Moderna vaccine. So I do think it's really important to have, and I do think it would be really impactful here in the US. I think a bigger, kind of a more global perspective, this is an amazing vaccine for the world. And so think about places that are, very hard to reach. They have very poor access to healthcare. Those are places where you can get out and get a J&J vaccine to people that absolutely need one, but don't have access to get the double shot, or don't have the ability to keep, the Pfizer vaccine frozen at those requirements that it needs. So from a global standpoint, the J&J vaccine is absolutely critical.
I want to talk a little bit about Utah more specifically. There seems to be a lull in appointments being filled lately. Dr. Dunn mentioned this yesterday during their presser, that the demand or the want for the vaccine is a lot lower than it was a few weeks ago. Is there a way to address this if someone's trying to talk to us about getting the vaccine? What's the best way to tell our peers that it's safe to get this vaccine and to make sure they go get those appointments?
Yeah, so what you're seeing at the state level, we're seeing it with Intermountain data as well, is that you're seeing kind of those people seeking vaccines have kind of plateaued. And so we've reached almost everybody in that 70 years of age and older group. We're at a vaccination rate about 80, 85%, which is just tremendous. But as you look down at the other groups, the 60 to 69, 50 to 59, you start seeing that kind of that plateau. And that likely is because the people that wanted the vaccine and absolutely was going to get the vaccine have gone out and got it, right? They said, sign me up. I'm the first on the list. I'm going to go wherever I need to go. I'll drive 50, 60, 70 miles, get me vaccinated. And they've gone out and done it. And that's awesome. And they're there and they've done it. Now, I think what we're seeing is we got to get to that population that are more on the fence, the ones that are kind of hesitant about it, not quite sure about it. Those are the people that we really need to impact and convince to say, hey, we really need to get this vaccine just for the public health of Utah. And I think those are the people we need to talk to, and we need to have frank conversations with them, non-emotional conversations. We need to know why they are hesitant, what are information that we can provide. We listen to them, and we may, not convince them the first time we talk to them, but we continue to have these conversations about the importance of the vaccine, and it'll come. It'll come, and we just have to keep doing our best to get out there and make sure that we're having conversations, open conversations about the importance of the vaccine. I think primary care physicians and advanced practice providers, PAs, nurse practitioners, they're the ones that are going to be critical in this. People look to their physician. They look to the person that gives them healthcare for guidance. And we really need to continue this conversation. Every single patient, we need to ask about vaccination. And we need to be able to provide information to them. And that, Intermountain, we recommend vaccination to everyone. And so that's something that will come with time, and we just need to be persistent on it.
Do you feel like the pause on Johnson & Johnson is contributing at all to that vaccine hesitancy? And if so, what can we do to make people feel more comfortable if that pause is lifted?
Yeah, I do think that the pause and the reports of these adverse events certainly probably gave people a little pause and made them a little more hesitant in getting a vaccine. And I think it's our job to get out and really highlight that this safety program worked, that we've done the due diligence, we've evaluated the safety profile, we've seen if we've gotten any more cases in the time since it's been paused, and be able to speak clearly about the side effects that it could potentially cause, and the fact that they're incredibly, incredibly rare. And really for people to understand that, if we really want to move back to normality, if we want to move back to where we were, pre-March 2020, it's going to take all of us working together to get vaccinated. If we're at a point where we have 40%, 45% of our community vaccinated, that leaves 50 to 55% of the community susceptible. We're still at a high risk of seeing another surge, and a surge in patients that haven't been vaccinated, especially with these new variants, with this B.1.1.7 variant that is just incredibly efficient at transmission. If we move back to a period where we're all crowding in together, not wearing masks, I think about like gymnasiums, I think about concerts, that's a perfect setting for transmission of this virus. And I worry that if we don't get to that, quote unquote, herd immunity, and we go back to the way we were doing things, we're going to start seeing spikes again.
Dr. Dunn actually mentioned yesterday that we're seeing the variants in about half of the new cases that are being reported each day. How are the variants making it trickier to actually beat the virus? You kind of touched on that, but can you expand a little bit?
Mm-hmm. Yeah, so if you look in Utah, it looks like about 50% of the cases are due to B.1.1.7. That's that variant that was first described in the United Kingdom. And then there's the California variant, pardon me, the 4.2.7 and 4.2.9, which also are probably at a very significant rate here in Utah. So what we can say pretty confidently is that the variants that we've been tracking, California and UK, are the predominant viruses here in Utah, as is the case across the US. And that's data that the CDC reports out every 2 weeks. And it shows that these variants are now the dominant strains. And so what makes it hard is that these variants, they transmit better, meaning that it takes a lower dose of the virus to be able to cause symptomatic disease in an individual that's been exposed if they're susceptible. And so what makes it tricky is that as we take masks off, as we start gathering indoors, as we start gathering indoors in large groups, that those viruses are much more transmissible and can cause much more disease in an environment that doesn't have good circulation or ventilation, doesn't have protective equipment like masks. It makes that virus be able to transmit much easier and more people get sick. And so it truly is right now a race of the variants versus the vaccines. And I think right now we're doing well. We're outside, people are gathering, we're outside, we're not cramming into small concert venues. We're doing the right things. But if we go back to the way we were doing and are not implementing those public health measures, and this virus is still here, and there's a large proportion of our population that's not vaccinated, we'll see more cases, and we'll see more hospitalizations, and we'll see more suffering.
I want to switch gears a little bit to children, or those specifically aged 12 to 16. Is there any more data around when the vaccine could potentially be available for them?
Yeah, the latest we hear is potentially soon. It does not sound like that the FDA needs to have another advisory meeting. It does not sound that they'll have to have a meeting together. The FDA can take their application and make a determination because it's an addendum to their emergency use authorization of 16 and up. And so it could come, sooner than we anticipate. It could come in weeks. I would certainly say that it's going to come before next school year or next fall. And so it's something we're watching really closely. The data is excellent in the 12 to 15-year-olds, and I anticipate that in the coming weeks to months, we'll probably have an EUA for that age group as well.
Are there complications with that age group and even 16, 17, 18-year-olds? Because right now they're only approved, or 16 and 17 are only approved for Pfizer. Are there complications in getting that age group actually vaccinated due to them having to seek out that specific vaccine?
It's just they have to be able to go to a place that offers Pfizer. Moderna is the other vaccine, and the only reason that they're not approved down to 16 and not seeking approval yet for the 12 to 15-year-olds is because they just didn't study that age group. That Moderna trial went down to 18, whereas Pfizer went down to 16. There's no reason to think that the Moderna vaccine won't work as effectively as the Pfizer vaccine in that, the kids. They're the same vaccine. It's the same, essentially, RNA sequence. So we would anticipate them to work very, very similarly. The challenge is that in those age groups, we're just going to have to be able to offer Pfizer in areas that we can get our children into, and just be cognizant of that. You have to get the Pfizer vaccine. I think it's really important to get them vaccinated because, as we've seen, that adolescent group is a group that can definitely lead to transmission, and not just transmission amongst that age group, but transmission to parents and grandparents. We saw that very clearly in that our Halloween spike that we saw back in October. I thought that was driven by that adolescent group. And so we really need to get them vaccinated to protect us from a transmission standpoint, make middle schools and high schoolers safer, especially for the teachers and the staff in that area, and then also the parents. And, frankly, is that those people can get sick too, and they can get quite ill. And so it protects them as well, not only just it protects us from transmission.
You've talked about this a little already, but do you have any suggestions on how to approach a conversation about the importance of the vaccine with a family member or friend who is pretty anti-vaxxer to begin with, or is skeptical of the science behind the safety of the vaccines? There might be a situation out there where a family member is really opposed, but they are willing to at least listen to you. How do you start that conversation?
Yeah, so, in my mind, kind of break this up a little bit in two different camps. There's the people that are true anti-vaxxers. They're the ones that are absolutely will not vaccinate themselves or their children. And they have these just beholden beliefs. And I just think of them as the anti-vaxxer. Those people are really hard to convince otherwise. But they're the minority of people. That is not the people that you typically encounter. That's the minority. And so our focus really needs to be on those that are hesitant. And people that are hesitant, they're not anti-vaxxers. Like, let's not confuse it. These are people that are just hesitant. They need time to understand the science, understand the implications, and it's our role to speak to them, compassionately. And one of the things that I like to do is not throw the science at them. You can't have this conversation and answer all in scientific terms and think that they're going to change their mind. What I like to do is kind of tell stories and make sure that they understand, why it's important. If they don't perceive themselves as a risk, think about and tell a story about how they could potentially transmit to a loved one, to somebody that they love, somebody in your family, and try to help them through that process of understanding why. I understand if this is not something you want to do, but please think of this as a community effort and allow them to come to that realization, like, yeah, if we want to get back to what we've been doing, we need to be able to get vaccinated and get our community immunity up. And so I think approach them with compassion, approach them with concern, try to understand their viewpoint, and then have a conversation about it, and have a conversation about why you think it's important for them to get vaccinated, and try to have them see your side of the story to really try to reassure them. Those are my thoughts.
I think those are great suggestions. Someone made a comment on the live around their specific hesitancy. And I think if you have questions around your specific health concerns, if you're pregnant, anything along those lines, talking to your primary care provider is also a great way to get more information to figure out if the vaccines are safe for you. So just a suggestion for that person. But I want to talk about booster shots. The Pfizer CEO mentioned, I think a week ago, that he anticipates a booster being needed in the next 12 months. Currently, the CDC is not releasing any data around when a booster will be needed. Do we know anything more about that? Is there any sort of data that's come out yet to say one way or another if the booster shot's going to happen?
Yeah, so keep in mind why we do booster shots. Booster shots are done for one of two reasons. One reason is that the vaccine effectiveness has waned. So you get the shot, and then over the course of time, the effectiveness of that vaccine goes down. And then if you give a booster shot, you boost up your immunity and you're good again for a period of time. Okay, so that's a booster, and a boost your immunity. The other reason to get a booster shot is to match your immunity to the circulating strain. Okay, and so it could be that you get a vaccine, that vaccine's working great, but now there's a virus in your community that can escape that vaccine that you had gotten. And so then you get a new shot to protect yourself to that virus. And so a great example of that is influenza. So influenza, we get booster shots every year, not necessarily because our immunity is waning, but because influenza mutates so quickly and so frequently that we have to match our immunity to the new strain. Okay, so when you take that and think about COVID-19 or SARS-CoV-2, we don't yet have any evidence that our vaccine effectiveness is waning. Okay, so we have data at the 6-month point showing that those vaccines that were given in that original Pfizer trial work great. In 6 months, it still looks good. I'm sure we'll get 9-month data and 12-month data from that study, and also from Moderna as well, and we'll assess whether or not that vaccine's effectiveness is waning over time. Right now, we don't have any indication that we're going to need necessarily a booster shot for that reason. The reason that we would need a booster shot is to match the variant that's currently circulating. And so the variants that we worry about is the 351 variant that was originally identified in South Africa, the P1 variant that is in Brazil. And quite frankly, I worry about a variant coming out of India. India has incredible transmission right now, an incredibly population dense area. I'm sure we're going to see a variant coming out of India due to the vast amount of transmission there. And so what we would do then is if that variant, especially if it was able to escape the vaccine, we would then give a booster shot to match that. And so it really is kind of time's going to tell on this, and whether or not there's enough variant that's in our communities that evades the vaccine, whether or not we'll need to get immunized again. And then we'll follow really closely the vaccine trials that are ongoing, but also our own research within Intermountain about the effectiveness of the vaccine over time. And so time's going to say on this. I suspect that in time, we're going to need another shot for SARS-CoV-2, whether that's due to waning immunity or a variant, who knows at this point.
There's a couple people that I've been following who are in the clinical trial, and it's really interesting. They get tested for antibodies every week to see where their antibody levels are for the different variants. And I think it's quite interesting to see that however many months now than the trial started, that they're still having a really high antibody reaction to the virus. So it's good news, which is great.
Right. Yeah, and what those trials are going to help us with is whether or not a blood test to look at your level of antibody, whether that is what we call a correlate of protection. It'd be really, really nice if we could take somebody's blood, say your antibody is X level, because it's this level or above whatever level, you're immune, right? That would be ideal, is if we could get a blood test to say, oh, your immunity has waned, we need to give you another booster. And that's part of the reason why they're doing those blood tests in those clinical trials, is to try to identify what are called correlates of immunity. And if we can identify a blood test that could identify when people have lost their immunity, that'd be a really great situation for us to have.
Another question for you, is it true that those who have had the virus are generally experiencing more intense symptoms following getting the vaccine itself?
Yeah, great question. So there is some observational data that in people that have had COVID-19, clinically have had COVID-19, and then get their first shot of the vaccine, that they get pretty symptomatic and side effects after the first shot. Most people that haven't had COVID-19 take the first shot, no problem, don't react, maybe have a sore arm, and then their second shot, they can get pretty symptomatic with fevers, chills, kind of feeling run down. And so what that first shot after somebody's had COVID really does is that's their booster shot. And so that's the shot that they get symptomatic with, versus people that haven't had COVID, they get pretty symptomatic or can get symptomatic with their second shot. Completely and totally normal. There is some data, and there's a lot of people talking about this, is that if you've had COVID-19, that you may only need one shot of Pfizer and Moderna because that's truly your booster shot. We don't have any good clinical data on that. That's work that's in progress, but that is something that may come to fruition in the months to year, is that people that have had COVID only necessarily need one shot, which acts as the booster.
That's interesting, and it makes sense. I think it's important to note too that if you don't get side effects, don't be alarmed. I had zero, and I asked you that and wanted to make sure that just because you don't have side effects doesn't mean that nothing happened to you.
Well, I would say you're one of the lucky ones, because I had pretty good symptoms after my second shot. Keep in mind that in those studies, only about 50% of people got side effects. Yet the vaccine was 95% efficacious, right? So yes, even the 50% that didn't get symptoms in the study were very well protected. And so, yeah, if you don't get symptoms, good on you. That's awesome. But if you do, know that they're temporary. They last between kind of 12 and 24 hours, and then they go away. And so that is just your body's response to the vaccine, making antibodies and getting revved up.
You mentioned India already, and I want to just touch base on it a little bit more. India had its highest case count, which made the world's highest case count a couple of days ago. I think they reported over 300,000 cases in a single day. Is there any chance that because people are traveling internationally, domestically, that we could start to see a surge here in the US or Utah specifically because of India?
So India is in a really bad spot right now. If you look at their case curves, they're hitting rates that we never hit here in the U.S. or in Utah. Yes, or 2 days ago was the highest number of cases ever recorded on our globe. And that's driven a lot by India and some other countries that are going through pretty significant surges. What I worry a lot about in those countries is all the suffering. I mean, it's just tragic. It's awful what's happening in India right now. That is also a breeding ground for variants. When you have that much viral transmission, those are just so many opportunities for that virus to develop a mutation, and that mutation could be, deleterious in the fact that it causes more severe disease, leads to increased transmission, affects our testing, or is able to escape, from the protection that our vaccines provide us. And so, yeah, I do worry about that as just a continued entry point of more SARS-CoV-2 into our country. Yeah, absolutely, we are concerned about that. I'd say my bigger concern from a public health standpoint is that that's a breeding ground for mutation, which could potentially then come to the U.S. And that mutation could be a mutation that, renders our current vaccines ineffective. And so that's our biggest concern. Obviously, our biggest concern is the people there in India and the fact that they don't have the healthcare infrastructure right now to care for them all. But we need to be focusing on that for that reason, and also the fact that it can come to us in the form of variants and also just more transmission in our communities.
I think the key message from there is, if you haven't been vaccinated, please go get vaccinated, so that if it does happen to get here, we have more protection against it. So that's great. Yeah. Do you feel like the California variant is a threat at all to Utah, or is that one less so? Because it's not as severe, or there's not as much of it? Have we seen any of that here?
Yeah, we've seen plenty of the California variant. So that's that B1, 427, and 429. We like to call them the Beach Boys. That's been our kind of slang in the biz. So when you think about the California variant, we know that it's more transmissible compared to the original virus that we saw here in the US, but not as transmissible as the B117. So yeah, it's an issue because it can lead to increased transmission. That said, B117 and the California variant and the New York variant that we haven't talked about isn't much, here in Utah. The good news is that those are covered by the vaccine. That if you get vaccinated, you are protected against those variants. And so the challenge for us here in Utah, whether it be California variant, which is certainly prevalent, and the B117 variant, it's just that they can transmit very, very easily. And so I wouldn't say that the California variant is a bigger concern. I would say it's on par with the B117 in terms of the way we think about it, in terms of potentially leading to increased transmission. But they're both fully covered by the vaccine. And whether or not they cause more severe disease is kind of, I think, a question mark, especially as it pertains to the California variant. There is some data that suggests that the B117 does lead to a little more severe disease than the regular virus.
Last question for you. Dr. Andrea Dunn announced that she is moving to the Salt Lake County Health Department in a little bit. I would love to get your thoughts on what it's like to have had her leading the epidemiologist section of this during this last year. What does her leaving the state mean, or what does her leaving that job mean for the state specifically, and what does it mean for Salt Lake County as well?
Yeah, I saw that Cox made a comment, Governor Cox made a comment that he was going to put out an executive order to say that she can't leave that position, which I thought was great, and I wish he could do that. She has been such a constant voice for the state of Utah. She has been such an advocate for science. She has been, such a stable person that we've been able to look to during this time. And she has had a really hard job to be able to balance the politics and the science. And I think she's, walked that line gracefully and has done just an incredible job for the state of Utah. So, we owe her a debt of gratitude. I know Intermountain has worked with her extensively over the past, 15 months. And we hope that we continue to get to work with her in Salt Lake County. And we have been just so fortunate, so blessed to have such an amazing state epidemiologist. I mean, we owe her, so much. And, Robert Gerke wrote an incredible article on her that was in the paper a couple of days ago that I think just hit the tone perfectly. And the fact that, she has been such an asset to us and such a role model too for, women in medicine. I think that's just been so amazing. So, yeah, she's been awesome. Let's hope she doesn't ever leave Utah and that she continues her good work in Salt Lake County.
I can't imagine having to be an epidemiologist during a pandemic. It's probably not something I'm sure it's something you prepare for, but not something you really necessarily expect to happen during your career. Same with you. So it's been really interesting to see her leadership at that role. So I'm excited to see what happens. So.
Yeah, I'm too. We growing up, like in training, we would look to those infectious disease clinicians that were boots on the ground for the HIV pandemic. And we would look up to them in just awe about what they went through over the years with the HIV pandemic and the early years without treatment, and then moving into a period where we could treat this effectively. And we look up to those people and we put them on a pedestal of, what they represented for science, what they represented for humanity, what they represented to their patients. And, Angela Dunn will be in that same type of circle. Well, she will be looked up to with just such awe by people that come after her. And I think that's something that she'd be proud of.
Hard shoes to fill. Eddie, is there anything else you'd like to mention to us today before we take off?
Get vaccinated, spread the word, talk to people with humility, talk to people with compassion, and point them to resources that could help them change their mind. Point them to their primary care physicians and advanced practice practitioners to have that discussion, and really encourage everybody who come across to get vaccinated. Now's the time to do it. And we want to make sure that we continue to have an incredible summer and an even better fall, and then be able to, move safely indoors, as, fall turns into winter. So that would be my plea.
And if anyone has not gotten vaccinated who's listening or would like to learn some more information, you can go to intermountain.com/COVID vaccine. We have a lot of resources and educational material on there. And also there is a schedule a vaccine link as well. Dr. Stenehjem, as always, thanks for joining us, and we'll chat with you later.
Yep, you got it.